Yesterday, one of the questions I think you weren't there that time, Naveen, but Sanil had asked me this question about public health. You were there, Acha. So, in response to that, I had said that that's what I would like to speak about today. Um, so today, what I will talk about is um, I've titled it Foregrounding the Public in Public Health. The patient, the doctor, and society, in which I am talking about the significance of the Ayush systems in the framework of public health. As a student of politics, yesterday I didn't foreground that aspect too much. But today I would like to begin with my disciplinary background, which conditions a lot of the questions that I like to ask. And of course, as we all know, all of us are researchers here. So the question that you ask will give you a certain kind of answer. So it's important to state what questions I'm asking. What I wanted to begin with is to understand when we say public health, um, to adapt what we usually ask, it's the trite understanding of democracy, of, for, and by the people. So I think an important question to ask is when we talk about public health, is it health for the public? Is it health of the public? Or is it health by the public? Or is it a combination of all three? And it's important to recognize this because the way I see it, and how much time do I have, Sanil? Until 11? Okay. I won't speak until 11, then we can have some. Okay, fine. So, what I'm going to do is most of the points that I will speak, like yesterday, I will just put out the ideas. They will be quite brief, each point, because I have many things to say. With the understanding that the questions that are raised by any of the points that I'm making can be taken up in the discussion. Then I won't speak for too long and then invite questions. So, on this whole question of public health and what it means vis-a-vis the public, because the public, which is a vast and an amorphous kind of entity, the way we see it, that there are lots of different kinds of people, different social classes, different kinds of communities, different beliefs, different practices, and so on. So when we say public health, we are really trying to make them all into one category of the public. And then we are trying to give them a health system that we believe works for all publics. So in a sense, public health works with the notion of a homogeneous public. And I think nowhere in the world is there a homogeneous public. And the sooner we begin to understand the character of the heterogeneity of public, that we will have a better appreciation of what public health could be or even should be. So I, begin with this particular understanding. And I do believe that, when we say heterogeneity of the public and that we need to recognize it, I am not saying, and I thought, I might as well clarify right at the beginning, it's not different standards of healthcare for different people. That's not what I'm talking about. The healthcare that should be provided to all people should be good, should be of a good quality, should be something that definitely improves their health status. And all the different markers that we have for assessing health status should be improved by the provision of health care. But I am simply asking you to consider that markers of healthcare, even if they are uniform, the way in which all these markers of healthcare can be achieved may not be uniform. And that should be fine. Why is it that they need not be uniform? Because, as I said, we are talking about heterogeneous communities. We are talking about different kinds of people. And what people need to be in a better state of health varies. And so the focus of provision of health for different communities should respond to that particular need. And for that, if we have to calibrate our notion of public health, we should have the bandwidth to do that. Second, of the public and by the public. For the public, we all understand. Public health is for the public. This we all understand. But by and of the public, what does that mean? A whole lecture can be done just on this. But I just want to share a basic idea that all of us have an understanding of what accounts for our good health. What works for us, what does not. And while it can be fair, it can be quite individual as well. I'm not in this context talking about the individual, but I'm talking about communities and people that live in specific kinds of ecologies. For me, this ecology is very, very important because we all know it, that, whichever ecology you grow up in, that ecology influences our body constitution to a great extent. And so what we can get in terms of the best from that ecology is what keeps you the healthiest. So in Kerala, the kind of food that you would eat, the kind of practices that you would have for a daily, healthcare rituals, weekly, seasonally, and so on, would radically differ from those who live in the mountains in the Himalayas, for instance. Even between the Wayanad, the mountain areas in Kerala, and the practices in the Himalayas would be different. So these ecologies are very important, and a public health that can be tuned to local ecologies would actually be far easier to administer as well. This is not about having very different kinds of administrative structures. It is about having administrative structures that suit particular ecologies. And I'm arguing that, in fact, that is possibly a more logical way of managing. So if public health is something that we start from the ground up, what are the kinds of things that people believe, that what they do, and what is it that is understood to foster good health in a particular area? And a health system looks at what are the possibilities. You can't look after everything, but what are the broad common possibilities that can be taken care of? Then the public. So what I'm trying to say is that when we talk about public health, we need to foreground the public in a somewhat more nuanced way than we are doing at the moment. I'll come back to this point more specifically later. But in this, I feel that if we start with this definition, then given that most of the Ayush systems are about maintaining health on the basis of local ecologies. This I said yesterday. We didn't have much discussion about it, but this is what I had referred to yesterday. So because Ayush systems are based on local ecologies, they can play a positive and very impactful role on providing public health. Now, when I say this, I want to say two qualifiers. One, that there may be many practices which are actually not good for overall health, even if people have been doing them for a long time. But every practice can be open to examination and critical examination at that. I am one of those who believes that I am part of a tradition that has actually been very reflexive. I said this yesterday too. We all belong to a tradition which has actually been very reflexive, which is to say, critical of received wisdom and most willing to open up to all kinds of new ideas and so on and so forth. So we all have grown up with this great sense of being very, respectful to received wisdom, to elders, and all of that. That's all very well, and I think that that's a very important aspect of the way we think. But that has never precluded questioning and critical questioning of received wisdom or elders, for that matter. This is what I have understood from my study of these traditional systems. So, creating a modern public health system based on Ayush systems includes questioning some practices which may not seem very doable, viable, or actually even just correct. And the whole point of setting up a system which is of the public and by the public is to actually engage with practices that already exist and to see how new practices can be set in place which are good for everyone else. Also, I might just add, and many students of public health and community health here, so I don't need to add this, but it's not just health qua health interventions that constitute public health. It is about sanitation. It's about a whole lot of other factors which have actually contributed to better health conditions in the last 100, 200 years. And that's very, very important as well. Urbanization particularly has created problems of sanitation, which we have responded to very badly in India. So that's something that we need to look at. Yes, if we don't have a history of very good traditional sanitation systems of the last 100, 200, 300 years, whatever memory there is, absolutely they need to be radically revised and they need to be faced with some kind of alternatives. There's no question about that. So I just thought that I would clarify. So when we are picking up things from of the public and by the public, have the public participate and involved and contribute to an understanding of public health, then that should include a critical appraisal and critical engagement with what is already available with the public. Having said that, though, there's so much that can be said on this area. I have chosen to speak on three dimensions today. One is, the experience of people working with community health organizations on the ground, and how community health is an idea that is carried by committed biomedical doctors who move to working with underprivileged communities, and what happens there. That's one aspect that I will be talking about. The second will be about the role of what in our writing and the literature that some of us have built up, we call the local health practitioners, who are not certified Ayurveda doctors either from the modern institutions or even from traditional orthodox teaching institutions. So what is their role and what is the significance? They are usually and largely identified, categorized as quacks. And many of us have spent some time trying to understand who these quacks are and what engagement is possible. Many organizations on the ground have worked with them. I'll talk about those briefly. And I'll talk about those with illustrations about the interventions that these practitioners have made in different kinds of contexts of the public, and how that provides a very important insight into their significance for public health. And the third aspect that I will be talking about is the role of Ayush systems in contemporary public health interventions, like especially during epidemics and during outbreaks. Epidemic is a very big word, but just kind of many different outbreaks, and also recognized widespread conditions like anemia. What kinds of interventions they have done, which have all been documented, and they're all available, publicly available information. So, which show that these systems have important contributions to make in the public health realm, and what these could be should be carefully looked at. In all of this, I do want to again clarify that when I'm talking about the significance of Ayush in these different aspects, I am talking about them because I'm in a company that may not be very familiar with their significance. And I talk about them as a complementary set of systems to that of biomedicine. I do not see medical knowledge systems as only in contestation. There are spaces of contest, no question about it. But I don't think that we need to privilege those over and above those where they can be simply complementary. And where public health is concerned, most certainly, we need to look at the complementarity, because the responsibility of public health is huge. There are different kinds of needs of the public, and if those needs can be better fulfilled by one system or the other, then that is how we need to approach it. Lots of interventions from government and so on, policy has happened over time. So as I said, it can not only be a whole lecture, but it can be there are whole semesters that are taught on this. Here I'm just trying to bring some issues to light. So the changing meanings of community health and its implications for the idea of public health. I'm talking about community health as non-state interventions by medical doctors that have been taking place all of the 20th century, but really a great deal after the 50s, after independence. And many medical doctors who felt that this was their calling, this is their responsibility. And we are a blessed nation because we have thousands of examples of doctors giving up very lucrative practices to go and work, because they felt that that was more exciting, that was more rewarding, etc. to do. And the experience of these doctors, they went with this idea that they are doing health for the public. That here are all these underprivileged communities, marginalized, poor, etc., deprived, and that they would bring good health care to them, and they would help them, overcome many of the crippling kind of setbacks that they have: infant mortality rate, maternal mortality rate, and then, of course, mortalities because of a number of other conditions of their existence and so on. So the experience of many of these doctors, and these are documented in various places. If you're interested, I can always share them with you later. So the experience is that they go in armed with this wonderful medical education that they have received, and they go in with very limited resources usually, and they go into um, work with those meager resources, and the stories are all very similar, that they have a small hut, the local people build them a small hut and said, oh acha, okay, you've come here to do some good, okay, we will help you. And so there's a whole setup for them, and they slowly build from that that small space that they have. And many of them, by now it's 30, 40, 50 years, many people have been working on the ground. Slowly they've built up hospitals, they've built up community care centers. They have other doctors, later generations of doctors who got interested in what they were doing, came and joined them, worked with them for a few years. Then they have people coming on a rotating basis. They form larger trusts of friends who are doing well, who are in standard kind of practice, but who feel that they should contribute. So they have generous contributions coming. Some of them get contributions from the state, but not necessarily. And many of them lead these extremely simple lives, but very rich in terms of the kind of health interventions they make with the community. And many of them, I've had the privilege of speaking to many of them over the last 2-3 decades. Their experience was that while they brought in very valuable inputs from biomedicine that they had learned, they were very valuable. There were some things for which they felt that the local communities had their own practices, which of course they knew nothing about. But because they were living right there and they were experiencing what these communities had been using, they would ask them. And of course, they were very skeptical initially. But as many of them say to me, that, Madhulika, it was like, I thought to myself, yes, of course, I've learned this medicine and all, and I've come here. But after all, these people have been living here for a long time. When they were sick, they had things to heal. They didn't always just die of every sickness that they had. So surely there's some logic to what they were doing. So they were looking for whatever solutions were existing in the community. Some of them were, they had initiative enough to collect those medicines, have them tested back in laboratories to see what is it that was active in those medicines. But as we all know, many of these formulations are compound formulations. They cannot be, what we were discussing yesterday, they cannot be assessed by the same parameters that biomedical pharmaceuticals are examined. But of course, at least you can tell what are the different molecules, what are the different components, what's exactly happening. So they figured that there's a great deal of value in the kind of medical practices that these communities had. And what I find is, in many of these places, there's actually a very healthy communication, dialogue between local communities and these doctors that work there. Over time, many of these doctors say that, we began to understand that they have very valuable things that we need to learn from, and they are more than willing to learn from us, whatever we have brought from our hospital training. So I find that there are so many community health groups in this country who have set up this model in some form or the other. Some may use more local medicines than others, that is possible. But there's always some sharing. There's always some dialogue. And there is, whatever contestation there is, that's a very healthy contestation. It's not a contestation meaning that, there's questioning. Why do you do this? Why do you do that? And so on and so forth. There's some kind of contestation, but it's healthy because, after all, the whole purpose, that the shared purpose of all of these people is that, we have to bring better health to the community. So it's a teaching learning process for the doctors as well as for the communities. So we must, as a student of politics, I find this fascinating because in a sense, modern knowledge, even the knowledge that I have, is such an empowering thing, not only because of the inherent value of that knowledge, but because it comes from institutions of power. You say, I teach in Delhi University. You say, I teach in IIT. That has a standing of power in society as compared to someone like yesterday, Sanil was talking about musicians. Like musicians who have no academy, who have learnt in the traditional way. And actually, most musicians still learn like that in this country. And it's only when they acquire some absolutely superb status that people will recognize them and give them. But for me, I'm a professor in the university, and it's a no-brainer that I would be given some deep respect. Now, I'm not saying that I just got here by chance. I did work and so on. But it is an undue kind of privilege, which is an uneven playing ground. So then in this kind of situation, what happens is, and I can say that, in terms of politics, as a student of politics, from, those of us in our discipline who study elections and who study Indian politics on the ground. Yes, you have your theories, you have your, statistical understanding and so on and so forth. They all say that, when you go out to speak to ordinary people, you will encounter the most amazing political insights that you have never heard in a classroom. Now, all of us, I'm sure, this is not something surprising to anyone. But the point is that are we in a position to accord some legitimacy, some veracity to that insight, such that it becomes part and parcel of an understanding of politics, of an understanding of medicine? This is the question. That's why, for me, it is a question of the politics of knowledge. That we need to understand that we are in uneven structures of power when it comes to certain knowledges that there are in society. How we exercise that power through categories, through concepts. If we become conscious about it, then that helps to grow the knowledge. That is my argument. So when we use categories like science, evidence, and so on, it is, it's always a good thing to keep revisiting. What is it that we mean by this? Why do we use it in this particular way? Why do we use it in a different way when it comes to other knowledges? Why? The why question is all important in science, no? So this is what I find a lot of these community health people do. And as a result, these doctors have built up a huge amount of trust in these communities, and they themselves have a lot of respect for the communities and the knowledges that they have. And they use these things, these knowledges judiciously. Nobody is buying into the other completely. But there is a healthy, judicious application of what knowledge there is. It does not go through any trial except the actual trials of people using them, and sometimes suffering and sometimes benefiting hugely from them. So I think that these have wonderful lessons. And very interestingly, in places where these people work, the state public health institutions are nowhere to be seen. They are not accessible, they are not available. If the people are in good health, it's because of these community health interventions. And I think that a lot of Ayush is alive because of these kinds of um, projects. The second that I mentioned that I would talk about is the role of local health practitioners. Now, in the hierarchy of health knowledge, these are at the bottom of the hierarchy, right? So, in different parts of the country, they all have different names. Because they are all totally local, and they always have local names. So 2 or 3 areas which I know little about. So in Udaipur district in Rajasthan, where I have traveled and spoken to many of these practitioners, they are called Hamjo Bhujo. Hamjo Bhujo basically means someone who understands the local. That's it. So Hamjo Bhujos are people who have been trained. They're not necessarily, family, recipients of family knowledge or any such thing. They could have learnt it from any guru anywhere. And but their hallmark is that they practice within a particular area. That area is important because that area has its own ecology. They know all the flora and the fauna of that area. And they can tell you each and every plant that grows in that area, what kind of medicinal uses it can be put to. And the local, and these are areas, I don't know if any of you have been to Udaipur, but it's a tribal district, and it's very sparsely populated, small hamlets at great distances from each other, and in that very harsh, semi-arid, it's not fully desert, it's semi-arid. It's a very difficult terrain to live in, at least for people like us who, have no idea how people live in terrains like that. And you would think, really, Ayurveda with so few, so little flora to begin with, But when I sat with local health practitioners everywhere, they have a long list of plants and they can tell you what they have been doing with it. And local people depend for primary health care. They depend on them. Now, many doctors sitting here, we all know that I sort of count myself half a doctor, anyway. I mean, medical doctor because of my association with you people. We all know that primary healthcare is the most important. Everyday healthcare for people and communities to be able to access, that is the most important thing. And in this country, if there's something that does not work in most places, it's primary healthcare centers. There are reasons for it and so on. And precisely why, and we know why PHCs don't work. I believe that these are practitioners who can actually carry the responsibility of providing primary health at the community level. And they are people who belong there. They have a legitimacy amongst the local people. They have knowledge. They do good work. And they do bad work, like all doctors do. It is important to have them certified. So just give you an example of one organization in Udaipur that did this work. They actually initially what happened was that there was a diphtheria outbreak in Udaipur district and a couple of other, and children were dying in thousands, and you can imagine the distress. And this woman who actually led this whole organization, a woman called Bhavar Dhabai. So Bhavar Banerjee was going around. She was working with a sort of NGO and desperately trying to help with dealing with this diphtheria outbreak, whatever way they could. And she said that, it was so painful and it was so hard because nothing seemed to be working. Then someone told her that go to so-and-so district. The children are not dying. They're getting diphtheria, but they're not dying. So she thought, goodness, there's a place like this. So she went to figure it out. And there she found this Ved who had this formulation. He was giving the children this medicine. And he explained down to the last detail exactly how he makes this medicine. And he said, look, I'm a small Ved. I live in this place. I'm making medicine, small batches, and I'm giving it to the local children. But if you want, please take my formulation, go and give it to whichever children. Children should not die. So this is exactly what Banerjee did. She took his formulation and persuaded other places, other people that, can you take this, because this is how the children in so and so place were saved. So that actually helped check the diphtheria outbreak. And then she got really fascinated as to what this was. And interestingly, she said, that how is it that this particular person had this formulation, but there were other Hamjobujio. He was a Hamjobujio, but other Hamjobujios did not have it. So it's a fact that all healers don't have solutions to all problems. They know many things, but they may not be able to handle something as serious as diphtheria. But some of them might. So the task of someone trying to provide public health would be to actually document who knows what, how that can be helped, and to draw a baseline for primary health care to see who all can provide these things, etc. So this is a drill that you and I understand. We know how to do. But what I'm saying is that we need to do this drill for knowledge that's already available on the ground. But of course, nobody was willing to take this seriously. I mean, the diphtheria, when he gave the medicine and the children survived, that was okay. After that, to take them seriously on a whole range of things was not possible. So then she set out to create this whole exercise by which, at first she said, because, these Hamjobujios were challenged even by Ayurveda doctors, whether they were traditionally trained Ayurvedas or BAMS doctors. So she challenged them to an open debate on disease conditions and said, okay, if you have this disease condition, how would the Ayurveda doctors respond? How would they respond? So these open debates caught on and they became quite a sensation, because here were the Hamjobujios, the best of them, who really knew how to respond and who had solutions and answers. They had knowledge. It's not about solutions. They had knowledge about how to deal with these things. So this then she decided that, okay, they need legitimacy. So she undertook this whole exercise, which I've written about and should be published soon. It is about an exercise of how to accord legitimacy to these, on the basis, rigorous exercise of how to document what they know and then go through a whole process of Ayush documentation, how that could be done, etc., etc. It's a long story. But what happens is that here, you don't need to move people across places and so on. You're using what is available locally, making sure that it is rigorous, making sure of what it can do and what it cannot do. So making clear protocols. So when there are certain other kinds of conditions, then these doctors are advised, these Hamjobujios are advised to send people to bigger cities or towns for intervention by biomedicine, to recognize the limits of any knowledge as well. So this is one example. The second example is that of abject poverty. This again I've seen in Madhubani district in Bihar, where, typically because of huge migration, people have moved out, men have moved out of villages. And then there are these women, old people and children left in the villages, just basically to fend for themselves. They are doing the agriculture, they are doing the farming, and trying to eke out a living. And we all know that farming is such a non-profitable activity, especially if you are, really at the bottom of the hierarchy in terms of access to access to markets and so on. And you're being taken for a ride by artiyas who are the intermediaries and so on. So this small NGO in Madhubani district, in a place called Ghogadia, they had started with the intent of improving health and working with traditional medicines. So one of the things that they did was to have saplings of medicinal plants, which they invited the women to come and take the saplings from them. They gave them with a clear instruction of how it should be planted, how it should be nurtured, and how it can be used. Now, for everyday, small, basic things for which they don't have to run to a doctor who's non-existent in the PHC. Now, many of these things the women already knew, but many of the things they learned afresh. But the most important thing was, and this is an issue that comes up with every single organization that works, that what is the point of trying to treat disease when people have nothing to eat? The real disease is malnourishment. It's not a disease, but the real condition is malnourishment. How do you deal with that? So this NGO then helped these women by giving them not only saplings of medicinal plants, but of vegetables, because they were growing grain anyway. So gave them vegetables, and with the rider that whatever vegetables you can grow, you will eat. And when you have a surplus, you sell. And one would think, what kind of a model is this? It worked so well because suddenly the nourishment level of that area slowly started going up. Nourishment went up, obviously people became healthier, and so many of the other markers started to improve. And then using the medicinal plants the way they had been taught and way they already knew, that sort of came into play. Now, this is work in progress. I mean, I met these people 5-6 years ago. I haven't been able to go back, but I talked to them, and this is the sense is that this model is at least helping them, because the most important thing is that in this, their own nourishment as well as their own health is in their hands. They are not dependent on an institution which is remote, which is unreachable, which they are not able to really get any benefit from. There is another example of an organization in West Bengal, which works with traditional Chinese medicine, interestingly, and began with working on de-addiction. That's a long story as well. So lots of stories like this, but just wanted to say that, but I won't go into the detail just for the sake of time. So these kinds of interventions on the ground show that when these knowledge systems are used very systematically, very cautiously, and keeping totally an open mind about what is it that the people need, what do they have, what help can come from outside. And when you create a kind of system which is always specific to that area, as I think someone said, Madam said, I think yesterday, that one size does not fit all. And this is a country in which you have to have everything locally specified. This is what all of these interventions do. And these are few stories. There are many such. The unfortunate part of a lot of our experiences is that they number in the thousands, but they are all interventions by good, decent, good thinking people and good acting people on the ground. They remain local stories. And the modern way of looking at any kind of successful story is to ask, so can we scale it up? Right? But we all know that if one size does not fit all, that kind of scaling up is not what we are looking at. The question that we are asking is, can this be done in other places as well? So in fact, we need a notion of scaling out. And when we see, in fact, many of these models can be scaled out quite comfortably, because every region has something to offer, and for every region there is a government intervention structure in place which can potentially be used to work with what is available locally. So in this sense, the role of local health practitioners, which has been dismissed as, who have been dismissed as quacks and not taken seriously. I think a serious critical engagement with many of these practitioners in the South, in Karnataka, I know at least that they are called Nattu Vaidyas. And in Bangalore, this organization called the Foundation for the Revitalization of Local Health Traditions has been working now for 35 years with Nattu Vaidyas to document their knowledge, similar kinds of, with Bhavar Dabai. In fact, Banerjee and FRLHT have been in touch for a long time and documenting, using, and thereby also creating, you see, lots of talk of responsibility yesterday. Let's not forget that at any level, when people heal, they do feel responsible. The only responsibility that comes with a legal noose around your neck is not the only kind of responsibility. People do have a sense of moral responsibility when they take up the business of healing. There are unscrupulous people in all walks of life. It has nothing to do with the knowledge that they come with. No knowledge comes with an innate kind of unscrupulousness. That's something that we have to dissociate. So what we are looking at is the possibility of using knowledge that we already have to enhance it and to actually then see how we can create a health for the public, which is also orphaned by the public. That's actually a more doable thing in terms of just finances, in terms of infrastructure, in terms of public and local participation, where people feel that, okay, yes, this is being done for us and we have a role to play in this. So there's an active involvement of the community. And I work on other knowledges as well. You see, I worked on medical knowledge for a long time. For the last 15 years or so, I've been interested in many other knowledges, and many traditional knowledges work on the principle that the community is involved in making that knowledge work. And I can give you numerous examples, especially about conservation of water or use of water, water management systems, in which entirely done by communities. And we have to understand there are problems with that, lots of problems. When communities are organized and they do wonderful work, we must also remember that these communities are deeply patriarchal, deeply patriarchal and maddeningly patriarchal sometimes. Someone like myself, intolerable. And they are also deeply hierarchical and casteist. Those issues are also there. And my position is that I'm interested in the knowledge and interested in the community wielding its knowledge, but the community also being questioned and challenged for its patriarchal and hierarchical practices. No question. So if there is one beautiful thing that I've learned from modern medicine and modern science, is that all human beings are innately equal. That cannot be challenged. And so if that's one lesson of equality that I learn from modernity, then the two banes of traditional practices, which are of patriarchy and of caste, those can be challenged, and they need to be challenged, even while we try to work with the knowledges. So what I'm saying here is that we don't throw the baby out with the bathwater. There's important stuff to be retained, we retain those, but we fight the aspects. And I'm using a very traditional, harsh feminist word, which is to fight. But I think that, there are various modes of fighting, but it's important to fight these deep negative aspects of these knowledge practices. Just thought that I would add that rider there. And the third thing that I wanted to talk about is Ayush in public health interventions already that have happened. Two things, which I won't talk in detail because these are very well documented. I'm happy to share the article. Sorry, I should have done it earlier, but I'll do it now. Two very important. One was actually is on an intervention by Tamil Nadu government on anemia with Siddha preparation. This was at least 20 years ago. It's a very well documented intervention where the Siddha practitioners. The interesting thing is that Ayush has been, this government may claim that they are the ones who have made this ministry and so on. But the work of this ministry and the fact that it became a separate department and so on, it became a separate department in 2001. And it was functioning with a full-fledged system and infrastructure for even before that. Even though there is this recognition accorded to them by the government, whenever they actually want to make any interventions, they have to fight tooth and nail. And all the time it is about what evidence, right? So in this anemia intervention, the documentation that the Siddha, which I was talking about yesterday, that there's a lot of documentation done by these research councils on the efficacy of many of these medicines. So they used that documentation of efficacy, brought it to the ministry, persuaded them. And so in Tamil Nadu, they had this program in several districts. I should have remembered the exact details, but I can send those to you as well, where there was this intervention to administer this particular formulation to women who were identified as anemic. And it was documented, their progress was documented over time and systematically shown that their anemia was something that was taken care of. So Siddha doctors in Tamil Nadu, anyway, they have a very important place. And they were able to establish that this is something that would be an effective public health intervention. What is most important is Siddha's intervention in different kind of fever outbreaks leading up to COVID-19. And again here, when we talk about how different knowledge systems work, yes, they don't have a germ theory of disease, that is true. But they have an understanding of keeping the balance within the body such that the germs are not able to affect the body. So that's a different approach. And 64 different kinds of fevers are listed in Siddha, which cover symptoms which we identify as viral fever or as dengue or as chikungunya, and even the fevers that came with COVID-19 and all the associated symptoms. So whether it's nausea or it is, hurting behind the eyes, all of these symptoms are associated with the different categories of fevers. And for these fevers, for every category of fever, there are different kinds of formulations, which have been used again and again in Tamil Nadu, including during COVID-19. Now, the interesting thing is, this work is done. It helped keep the mortality low, or I'm not referring to all the details because it's all there. And it kept the mortality low. You remember that big story about the Jamaat groups that had actually come from, I forget the details, in Delhi, and then they were actually originally from Tamil Nadu. And so they came and there was all that hoo-ha about how it was going to spread COVID and so on. But actually, one of their students in Tamil Nadu, she was studying Siddha. And when this whole thing started and those people traveled back, she took the initiative, medical student of Siddha. She took the initiative, and I know this story from the doctor who was actually working with them at that time. Unfortunately, has since passed away. But Tirunarayan Swami told me that she immediately understood that this could blow up into not only a political issue, but that it would affect the entire community. So as soon as those people came back, they were isolated, but the entire community was administered with Kabasura Kudineer, which is the particular decoction that is used for a fever that resembles the COVID-19. And for 15-20 days, everybody was administered this regularly. And that nobody from that community got COVID. And what is interesting is that because this then worked, and COVID went on for such a long time, then the Tamil Nadu government was persuaded to then administer Kabasura Kudineer across the state. Wherever they administered it, they were able to contain infection. Forget mortality, that was further. They were able to contain infection. Now, this is not some magical wonder drug. It is about approaching the fever in a different way, working at the right time. This is not critical stage dealing with COVID. It is dealing with COVID at a very early stage, preventing it. So therefore, it is no question that, it is at the preventive stage. But we all know, for instance, lockdown, as we were discussing yesterday, was seen as a preventive measure. Lockdown was not. And yesterday I learned that the person who suggested it himself said that, this is not something that can, or for that matter, the RT-PCR, all these are contested things. Whether they're contested or not, that's not my issue. My point is that these are all interventions that allowed for very positive outcomes for these particular communities. And if you ask me, okay, so if this was so wonderful, why do we not know about it? This is where the answer that I can give is, this is called the politics of knowledge. Why is it that the media will not cover? Now, this is a media that is supposedly supporting this government, and that it, all the kinds of positions that this government, which is supposedly a great supporter of Ayush, why is it that it did not publicize this whole question of Siddha medicines working in Tamil Nadu? We need to ask ourselves this question. Why is it that this does not become news? And what is even more interesting, that a couple of my friends did manage to write and publish this. I wanted to do an extensive study on this. I've created a whole proposal in detail, including hospitals, including, who I was going to collect the information from. Rigorous study. I had made out the entire protocol. Twice I was denied funding by organizations that were giving funding to study the COVID-19 pandemic. So they were giving money specially for any proposal that wanted to study how the COVID-19 pandemic was managed. But they will not give funding to somebody who wants to study how the Ayush systems function. It's a mystery to me until today why I was not given this funding. And this is the experience of others as well. So this is the politics of knowledge. You have the power to keep this knowledge limited so that people don't know why. It is to the benefit of the public. That is why I'm saying that it's not such an innocent thing to ask for knowledge of the public, because this is what exists with people, and it is for their good, and yet those in power do not want most people to know them. So therefore, I'm saying that there's so many other issues in public health, of course, and I decided to focus on just this, just to be able to tell you aspects about the relationship between Ayush and public health in ways that already exist, and which thereby demonstrate possibilities of what can be done with them in the future.
About that Siddha medicine which cured or protected the people from COVID, whether that was studied so that the other people also can be given. So whether it was studied or can it, in between you said certain medicines cannot be studied, that you said. So whether that was studied, this medicine was, any study was going on about that medicine? Is it useful?
Did I say there are medicines that cannot be studied? How can that be? I'm sorry, I might have miscommunicated. No, 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 no. There is every medicine can be studied. It will be studied according to different parameters. That I've been saying since yesterday. But
A
every
different parameter means, but how this Siddha medicine is useful for the COVID? How can it be studied? What parameter can be used?
because when the medicine is administered, what is expected to happen in the body with that medicine. Now, the point is whether you recover from the symptoms of COVID or not, right? Now, one way of seeing is, does it kill the germ? That is one perspective. The other perspective is, what enables the body to deal with the germ such that the germ does not live there anymore. That is the other perspective. Now, believe it or not, Siddha's perspective is the latter. So it is about maintaining what they call a pitta imbalance, which has been translated to understanding balance of certain kinds of enzymes. And so the decoction that is administered actually works towards maintaining a different balance of those enzymes, which then makes it impossible for the germ to exist. That is how people recover from COVID or many of these fevers that people contract. And not only there's chikungunya, there's dengue, all kinds, and these decoctions have been studied. There are
But
studies,
you said about some balance of enzymes. What is that?
that is see, I'm not a scientist, so I can't explain it fully. You can read it.
No, we have the basic science knowledge is there. Now, some enzymes, the Siddha medicine causing balance and all. What is the enzymes which is not balanced in COVID patient?
That you'll have to read.
No, not
No,
that.
no. I'm just saying that it is documented.
Ah.
I won't be able to explain to you exactly the way it would make sense to you as a medical doctor or as a scientist, because these are not terms that I work with. What I'm trying to say is, yesterday, you remember, I was talking about translating, that you have certain parameters in these medical systems which work. So they have their own language in which they explain. So there is a pitta imbalance.
So how can the critical questions can be asked about that parameters? That's what we want. So what?
So that's what I'm saying.
What measure? Yeah.
So I was saying that those parameters that they have worked very hard to translate them into terms that are understood by biomedicine. So when they
That I understand.
when they translate and they say that this is the impact that is going to have, and they can show you how that impact is going to help the patient. That is what we are looking at, right? That how is it that this medicine will give you an impact in the body, which you can measure and you can see, which will then lead to the patient getting better.
The COVID was there for 2 to 3 years, isn't it?
Yeah.
Whether that impact is measured, whether that was studied.
Yes,
that's
it was
what we want to
studied.
know.
Yes, it was studied. I can send you the studies.
Madhulika,
Yeah.
can I just ask for a clarification just to push that in?
Yeah.
I think the challenge which we are trying to start a conversation about, especially when we broaden it out into public health, is the challenge of integration, which you were talking about yesterday. Integration in terms of different kinds of knowledge systems, claiming different kinds of claims to veracity, scienticity, trust, utility, and so on. So the parameter, it is scientific to accept that the parameters of different frames would be different. I don't think there is could be a controversy there. One could always argue that one parameter is not valid for the other and so on. So there could be some amount of incommensurability between different paradigms or systems. Yeah. So My prod to you is to try to start thinking about what are the ways in which we could have a conversation about how do we discuss this difference, and in a public space, what are the ground rules through which we could create a conversational arena. I mean, set up. That's it.
I haven't switched it on. Daft. So what I want to say is that the terms on which integration happen are very important, and those need to be discussed. They have to be, there's nothing given about integration. If you have to start a conversation, I think first of all, you can start a conversation simply by looking at instances where interventions, public health interventions based on Ayush have worked. They've had the desired effect. And that desired effect is studied thoroughly. For that, the parameters will have to be created, acknowledging incommensurability, but also acknowledging certain foundational parameters which are common. They're not that different. It's the same human body, same disease, same issues. So, yes, to your question, that yes, these have been studied, yes, these have been published. I'm happy to send you everything that has been studied and published and shared with you. And these have been systematically, and they've been studied according to parameters that you would recognize. And don't ask me to explain them to you because I'm not a scientist. But when I read them, I understand, and it makes sense to me.
But somebody says, Siddha medicine people says about the enzymes. Who said about the enzymes? And what is the meaning of that word enzyme? Where it come from? Who found out the enzyme? What is in their mind when they call it enzyme?
It is not in their mind. When they take their formulation to the laboratory, they have it examined, they have it studied along with scientists who are trained to study these things. Then they are doing an act of translation from their categories to the categories that biochemistry understands. That is how they arrive at an understanding that what they are talking about can probably be understood as enzymes by biochemists. That is what I'm trying to say. They are not saying that they are enzymes. They are offering what categories they have. They are offering their medicine to you for analysis.
But when we hear the name balance of enzymes, we are totally confused.
Yes, I can understand.
So the point either you have to define that. What is this balance of enzymes? Otherwise, how can we understand? Anybody, even a student in 10th class knows enzymes. So what is this balance of enzymes?
Can I just say something? I think I've said 3 times already that these are published work. You can read it. I, as a lay person, when I have read it, I have understood something that may be completely inadequate. I have no problem in admitting that I have picked up something that made sense to me, and that is it is one category that I saw as translated from pitta to a certain kind of enzyme. Now, that does not mean that that's the entire explanation. I'm not even claiming it is. But I have said that, this is available, this translation is happening, and if you have the bandwidth to read and understand what they are saying, you will get an explanation of what they're trying to do. That's all I'm saying.
So, yes, this is in the journal Trials, which is a PubMed indexed journal, international journal by Biomedical One. Kapasuda Kudineer, a polyherbal Siddha medicine, reduced SARS-CoV-2 viral load in asymptomatic COVID-19 individuals as compared to vitamin C and zinc supplementation. Findings from a prospective, exploratory, open-labeled, comparative, randomized controlled trial, Tamil Nadu, India. One of the authors is Manikyam Ponnaiya, who is an alumnus of Sri Chitra. He took his PhD. He's a Siddha practitioner, but has a PhD from Sri Chitra. He is in ICMR at the National Institute of Epidemiology, Chennai. So I think there's something I would like to say is that the categories of Siddha, which is syndromic, I think I would prefer to say syndromic rather than this. It doesn't try to treat COVID-19 or
Yes,
dengue.
exactly.
It's syndromic. But that has been run through this knowledge categories that biomedicine has to try to make a support that. So, but this, you know, I think it's happening much more than we realize. I don't think it's not happening. I would like to draw attention to Arogya Pacha and Kani tribe. And there I would like to say it's not just about biomedicine, because the knowledge systems involved there is, I think, that the Tropical Botanical Garden and Research Institute. So that knowledge system is involved. And now we have TRIPS. It's the politics of ownership of knowledge is another system which is involved. And I think Amity and the TBGRI scientists are collectively trying to renew the patent. Some American, some Europe, I think foreign companies have tried to get the patent of that also. So I think a lot has happened in this. And I think it's just we need to update ourselves on, I think integration is happening at multiple levels, many ways, which probably we are not realized yet. We are yet to see that happening. Something I have published on is the Palliative Management Committee, and you should see the palliative care provided by Ayush. And I think sometimes I realize that I don't own my body. If I tattoo here, do not resuscitate, there's no guarantee that when I'm unconscious that I will not be resuscitated or I'll be plugged into a ventilator. I do not own my body. So that's something I've come to realize. And then and all of us will die, it's inevitable. So if it comes to a stage where I've accepted that I'm going to die and I've come to terms with it, then probably I'd much rather prefer dying in an Ayurveda hospital than Sri Chitra. It would be really scary to die in the ICU in Sri Chitra. So PMCs in Kerala, it's not exactly integration. These systems work in parallel.
Yeah.
They try to not to step on each other's toes. Okay.
Co-location, it's called.
Then, but then there's always the question of, being critical. So I've written in the IJME on the non-formal healthcare dilemma, whether to hate the player or the game. Okay. So, because sometimes they try to mimic what is happening here. And so when we look at it, I've been trained to look at a certain process in a certain way. And they have seen this from their perspective, and things they have picked up, they are now mimicking there. So it's like, doctor so-and-so with so many tails to that. And, doing suturing in a very, non-scientific way, so to say. And then shaving, scalp suturing. So first doing the suturing and then shaving, because what the person has seen is when a person comes back from the hospital with a scalp suture, that part is shaved. But we do the shaving first and then the suturing because we don't want the hair to go in. But then what this person was doing is suturing and then shaving. So I find...
as I was saying yesterday, sorry to interrupt you, but as I was saying yesterday, this person or many such people also might be adopting, and mimicking badly. Mimicking is always a bad idea, especially if you're going to mimic in knowledge practice. It's a bad idea. I've called it doubling and othering in my book in 2009. But all I'm saying is, while we acknowledge that all these, don't judge the practice of the system by the poorest practitioners, by the the least competent practitioners or the least reflexive practitioners, because the ones who are doing that research that has been published, and if you know this person, you know that these are people who take their own knowledge system very seriously, as much as they take the knowledge system of biochemistry or whatever it is that they are using very seriously. So it's not, it's not that kind of cobbled together kind of. Otherwise, it would not have been published.
No, it's not actually, and we do a lot of Sri Chitra because we have this, we have converted sleep into a very scary thing. If you see Google for polysomnography pictures, you have so many tubes and electrodes in your body. So we do a lot of that kind of research. Our polysomnography beds are always full, not always for treatment, quite a lot for research, and we are into looking into yoga and certain forms of yoga and change in sleep patterns, like that. So, and stroke rehabilitation again, we have one of the best stroke physicians in the country, or I would say the continent, Dr. Shailaja, and she's also into a lot of integrated research there. So I'm saying a lot of it is happening. So I find, I don't know, it's,
if it is being done and it has been published by systems that you recognize to be legitimate, if PubMed, if it's in the PubMed listing, then is it a question that can it be done? It must be done. No. Why would I be talking about it? Why would I be talking about it if I didn't think it was legitimate? I don't understand this point
now
of
let
view.
me just intervene here, and that's not related to this particular thing, which I think is very interesting. But because there are many community medicine people here, one concern I have is, I think the discourse here is largely about primary health care. And I don't know whether yesterday we were talking about biomedicine and evidence. But evidence, we seem to be very interventionist in what we are talking since yesterday morning. But there are, even within biomedicine, knowledge systems which are not aimed at an intervention. Maybe at some later day it may influence an intervention, but in biomedicine also there are many knowledge paradigms which are not interventionist. Now, biomedicine extent, because you started off by saying public health, biomedicine and health, conflating it, I don't know, I think needs to be again questioned. Health and public health again, because there's this concept of public health good. Sometimes improving women's agency can be a phenomenal public health good. So a lot of public health goods are not, a direct consequence of biomedicine. So, or an application in that way. And so I think the whole very interesting, and all the points I enjoyed the whole thing. But I think it's about primary health care, and there's many facets to public health beyond primary health care.
No, of course. That's why I said in the beginning that I am talking about a very limited aspect of public health care, of by and for the people at the lowest level. There are so many levels, and it's not possible. And for me, I thought I can bring value to the discussion on public health by bringing in these elements of Ayush and the role that it has in primary health care. That I didn't say primary health care in the beginning, but that was clearly implied. Yeah.
Yesterday you told us that look, Ayurveda is not something like a universal medicine. Ayurveda, not a universal medicine. Okay. What? But much more is ecological in nature, isn't it?
That's not how I put it.
Okay.
I said that there is no one Ayurveda. There are different
Okay.
kinds of Ayurveda that are practiced, even though there is a common epistemological framework.
Okay.
That's what I said.
Okay. So in that case, I was wondering, suppose there is something called Natu Vaidyam, right? So I used to consult a Natu Vaidyan in my district, which is in my neighborhood. So he won't treat. So I had a severe knee injury. Then I consulted him. I had X-ray and everything. Then I just thought maybe I knew him from my early childhood, so I consulted him. So then he told me that, look, Robin, suppose if you're here for minimum, if you're staying here for 20 days, only I could cure you. Suppose if you are traveling back to Delhi before that, then it won't work with you. And also, I cannot even take my cousin to him for treatment because he thinks that he is from a different father altogether. Because my cousin is from my father's elder brother, so he won't treat him. Because he says, look, this I know this family, they won't buy the medicines and they won't follow the prescription that I follow. So I am going to give you, so I won't treat them. It's a very clean and everything. But unfortunately, my father is very close to him, and he is also very willing to treat me too. Then the thing is that he doesn't give me any medicine at all. He asked me to wake up at 5 o'clock. Then I have to walk 20 kilometers, sorry, 2 kilometers. Then there is a paddy field there. Then I have to collect a flower from that place. Then after something like 2 or 3 hours later, I have to go to another place. Then I have to take something else from that one. Then I have to carry those 2 things back to his house. Then he will prepare a medicine with that one. Then he will ask me to apply that before the sunset. And things moves like that. But the next, after 2 or 3 days, he will ask me to collect the same flower and the same leaf, but not through the route that I have taken earlier. So he will direct me through different directions altogether. But after something like 13, 14 days, they really worked with me. Something like it really, because I developed this injury because of playing basketball. And then I have consulted the biomedicine too. Then they said, look, there has to be some minor surgery kind of stuff has to be done. But I was very much happy with this one. I found this treatment as more ecological in nature because it used not only the medicine, but also used the nearby, the ecological system also have been used because the route are different. In one route there is slightly sliding, there is hills and places like that. But in the second one that is not there in. And also then I have recommended this to one of my friend from Delhi. Then I know for sure that he can be treated there because he thinks that only the people in the neighborhood can be cured by his medicine, not somebody from outside. So there, no foreigner can be treated in Wayanad, that particular district, because he's a foreigner. Okay, so this is something I found is something like very ecological in nature because not only medicine but also landscape, everything playing. But in Ayurveda that is not the case. Okay, it's not too much of ecological aspect at all because it's already when you free a medicinal practice from its ecology to medicine, proper medicinal aspect, you are already walking to biomedicine field already. Okay, because if you're freeing it from the landscape, the lived space, then what is finally, it's by the end of the day, you could have an allopathic medicine out of it. What is so different in about it? So I don't understand what exactly you are debating about. Okay, if you're freeing a medicinal practice from its livelihood, I don't know what is the word for it, lived, we call it lived experience, life world, etc. Then the practice becomes something else. But now look, you can also derive another practice from the same mechanism this guy used in my neighborhood because he is using mechanics, right? Different mechanics. So you can also derive a universal science out of that practice too. Okay, so I don't know whether when we say that this is a unique practice and it's a unique episteme game, I really doubt what exactly is it unless and until we drop the life, the life world into it.
See, there are two different things that you're saying. In terms of the ecology, see, ecology can also be interpreted in different ways. One is this ecology, this is a fascinating story. And, this is one way of understanding the ecology. What I think, and you're absolutely right, that Ayurveda's focus on the pharmacopoeia makes it seem like it's just another set of different kind of medicines than that of biomedicine. That is where I would differ. I don't think it's a radical difference. I'm just explaining that Ayurveda's understanding of the body is of a different kind of ecology. The body itself embodies a different ecology, and that understanding that ecology will require certain kinds of pharmacopoeia, which is also about balancing the, and so it's not only about medicine. Ayurveda has to be about pathya as well. And that is very important. Everything that is going into your body needs to be balanced. So the body, the medicine needs to be balanced with your food. That's why. And also your life, daily habits. So in that sense, that constitutes a certain ecology, which is different from the treatment that your Nattu Vaidya gave you. So in that, so they are different, but in that foundational sense of having a different sense of ecology in terms of understanding the body, illness, and treatment plan is what marks it different from biomedicine. Now, the point is, we are talking about differences of approach. We are talking about differences of approach. We are saying that each approach has some value or the other. And anyway, in this society, most of us make the assessment as to which approach would count, would be valuable in what kind of situation. If you have a cold, then you can manage things with a lot of traditional medication. If you have cancer, you're less likely to do that, and you would go to biomedicine, and that would be seen as perfectly valid. So I think that if we can just accept this and work with it, in the context of public health and primary health care, the reason I raised it is precisely because of the value of the local. Because our biggest problem with primary health care has been to provide it at places where people need, which are usually very far from metropolitan centers or bigger centers of healthcare provisions. That has been one of our biggest problems. So I'm saying that here it's not as if we don't have a solution locally. We don't see it as a solution. If we begin to see it as a solution, start working with it, then we can have some benefit out of it. That's all I'm saying.
But thanks, Robin. I mean, this example of Robin, I've got different avatars. So one of the avatars I got some years ago, it's very fast. I used to use it in my class all the time. And the whole class will be like agape. I'm like, I'm not making it up. There's a guy here and so on. But I had three quick sort of responses I've had. One is that one way to do this conversation is to talk about what is that one system we want. And we name it, describe it, the qualities in it, local, lived worlds, ecological, responsible in terms of ecological responsibility to the people whom you care. We can do scientific, we can do all sorts of name calling then or aspiration. So then we are truth seeking. We want that one thing. So the conversation will end up with that. There is some utility, no doubt. The second is to say how the reality, if we say the reality is that there are a plurality of systems. And if we have a normative commitment of trying to respect each system for what it is. When I say respect, I don't mean I'm going to buy into their normative commitments, epistemic frames and so on. Just to take it as the claim comes and then talk to that claim in their own terms. Not to say, I agree just because you claim it. As opposed to taking it from my, I have this normative framework from which I'm coming. I'm going to judge my epistemic frames upon you, as opposed to trying to have a conversation with you about your frames in your terms. So then that's the second way of trying to think about how to have a conversation. And how important is this epistemic pluralism, commitment to that in a general conversation about medicine and humanities? That's the three things which came to my mind, which I thought might be useful, kind of a thing. What are the terrains in which are we studying medicine as somebody who is not trained in medicine? Or what are the other ways of engaging, kind of?
Misunderstanding is the word enzyme does not mean the same as what you mean. What she meant is something else, but no, the translation part, no, maybe this is not the exact enzyme which you mean what the biomedicine is saying. So that is one thing I wanted to say. And regarding the Kabasura Neer and other things, of course, there has been some studies, valid studies, and but they are all at the, as you told, about the primary level only. Once when it goes above that, definitely the biomedicine has a role, and all the COVID warriors or whoever lost their lives, most of them are only the biomedical physicians or whoever was in the ground. They were treating the patients, and many of them have succumbed to COVID also. We should never forget that, because whenever there is an emergency, definitely everyone, whoever says whatever things, they will come to biomedicine only. Till now, that's what I'm saying. Maybe in the future, I don't know how it will be. And ma'am, you were saying that regarding that shaving thing, the system, don't blame the system for the poor practitioner. And there are people who are published, these people of that system has to take it as their responsibility to bring that system into some level, so that everyone can sit across the table and talk in some term which is, we can understand things. Right now, we are not, totally, we don't know what is happening in the Siddha world. Same way, everyone, no, whoever is good at that system, they should come forward, or they should have a group or something to bring about the practice. I have known some Siddha doctors who just do the 6 months correspondence course, and they are calling themselves Siddha doctors. But I know you are not talking about them. But if I am knowing about them, definitely whoever is good at Siddha, definitely they will also know about this, because this course is being conducted by some organization. So they should take action, or they should, the government or whoever should take action. Only then all the system, the good things from the system can come to that. And many the Ayurveda doctors also, you were saying the big Vaidyas or whoever, they have withdrawn themselves. They will treat whoever come in search. Means many of them are not into the field because they are upset or whatever, like that, no, ma'am. But it is definitely the responsibility of the strong or the bigger people to take care of the system also, no, ma'am. We cannot say the system is separate, the practitioner is separate. So whoever is doing wrong and bringing bad things to the system have to be taken into account by the people who are really worried about the system. And that should come from within the system.
COVID was fought by valiant physicians, and we call them COVID warriors. I have complete respect for them. There's no problem with that at all. The point is that COVID was also fought by many of these physicians, and that is not known. I'm simply saying that we need to know that these physicians also made effective interventions. And I cannot tell you how many died, but I can certainly tell you how many did live, how many patients did survive because of their help. And the point is that if people live, it's good, no? So, but what is important is that nobody knows about them. Everybody knows about the physicians who cared in the hospitals and, how brave they were. And nobody can take away from that. Second point about, all systems that have, which I said that, don't judge the system by the worst practitioners, and that you're saying that it is the responsibility of the system. I'm sure you are aware, as a gynecologist, that there are many spurious practitioners of biomedicine also. Lots of them, right? And you have a medical association as well, which is concerned about them and doing, but it's not as if you're able to always check. This country is awash with doctors who have these 6-month type degrees or not at all, or LMPs or whatever, and they've always been there. And yet, even though we have strong regulatory systems for modern medicine, we are still not able to prevent them. So, which is to say, theek hai, you have your bad guys, we also have our bad guys, so what? I take your point that regulation must be implemented as far as possible. No question about it. But whenever there is, that is not the point. The point is that whenever there is a discussion about Ayush, people always refer to these spurious practitioners as if they represent what the knowledge system is about. That is the problem. You know, whenever we discuss issues with biomedicine, I would not say that I know all these compounder types who are giving all the medicines and, you know, that's a problem with biomedicine. The two things are not the same. All I'm saying is that let us not equate it is the responsibility that nobody can deny. It is a responsibility. But let us not, whenever we discuss what the problems or issues or value of any knowledge system, then we cannot begin by saying that there are spurious practitioners. That cannot be the parameter of the analysis. About the big Vaidyas who I was talking about yesterday, see, I said very clearly that there are some Vaidyas who do not think that they need to translate their Vidya into parameters of biomedicine so that other people can understand and legitimate. They feel, and that is their rigidity, that is their parochialism. They do not want a conversation, which is what Naveen was saying, that we need a conversation. They don't, and I would be critical of them. So that's not a good thing. I am not supporting them at all. What I am saying is that there are a lot of people who want to translate, who want to have conversations. And maybe, Naveen, you and I should do a paper talking to the researchers who wanted to have a conversation and who nobody wanted to converse with. You know, it's not as if I say, as I told you my own example, I wanted to do that research. I was not given the funding. Nobody gave me a rigorous reason for why they felt that my study was not valid and could not be funded. But I was not given. So it's not so easy. And this is what I call the power structure of knowledge. That is not as if someone who is already considered a lesser knowledge system can stand up and say, look, I want a conversation, and somebody will listen to them. No, it doesn't happen like that. So if Sri Chitra is doing it, it's because it would be interesting to see the institutional history of Sri Chitra and to see how is it that they actually created an institution where this kind of conversations towards an integrative understanding became possible. It did not happen overnight, and it did not happen only because some or the other doctor suddenly felt that, you know, we must have this is a process. And that process in which at least some biomedical doctors would have been open enough to at least listen to begin with. Then you can have a conversation, no? So that itself is a struggle, you know. It doesn't happen. And if there are no conversations, it's not because of not trying. And what is more, when there are conversations, people create huge databases, they create trials, they publish them. Nobody knows about them. That is, biomedical doctors don't know about them. What do we do about that? How do we, first you publish, first you do the research, then you publish it through the rigorous peer review process. After that, people say, we don't know what you're doing. What do you do?
These sort of discussions won't lead us anywhere. That is my practical experience as a practicing doctor. And because one thing, every modern medicine doctor, all will be biased when it, not only modern medicine doctors, but I think most of us are biased because it's a very emotional thing for us also. One fact is that, every doctor will have number of stories in which the alternative system has actually destroyed the patient, and you were the savior at last. And alternative systems, if I may call Ayush, people will have many other stories like the anecdotes which you shared. See, then we talk about the quality of evidence, how it comes from an anecdote to an RCT. And all these are jargons which I would say, of course, dialogue should happen, but all this doesn't. Because I, being a student of modern medicine, I have been through this through the whole point of my career. And finally, I have decided that I'm not going to talk in many of the occasions because everybody is, in a sense, fanatic about their systems. And I would not talk about that also, but I would like to talk about two other aspects. One is basically, as Madam told, we are not judging a system by its worse or mediocre practitioner or whoever we encounter. But basically, we are talking about the knowledge base of this knowledge. That is what I think. Because you have different systems. I studied in one, you studied in one, all this. And these are all refined systems through the ages. So everything has its own merits. And if I go and try to understand a homeopathic and Ayurveda practitioner, I'm doing with my own set of baggage. So it is not going to work in a way because they say dialogue should happen. I'm a person who have been invited to many of this. I'm an ophthalmologist basically. So I get calls about going how children should use specs, should not use specs, and what is your perspective. And we talk about our perspectives. But again, it's not, however objective we try to be, it's not taken very well. And talking about Kerala, we are in healthcare also, at least we are, I think we are, compared to the rest of India, we stand a little more in statistical level also. And I'm in a very kind of dilemma, like how to do. I know almost Dr. Manoj and Madam would have different stories to say. So another thing is the question of choice. Just in my purview, suppose I need to have a spectacle, my child need to have a spectacle. You can actually approach an Ayurveda doctor, a homeopathic doctor, or a modern medicine doctor. 3 people will give you 3 suggestions. Ayurveda people will tell you, you should put dhara and that kind of medical systems, which is they have studied. It is very true to their senses, and I cannot tell that it is wrong or right, or I cannot comment on that. I'll give them spectacles. So all this is right. But how about the patient? What is this choice of the patient based upon? Is it an informed choice? As a modern medicine physician, I know that if the child doesn't wear the spectacle within this prescribed hour, he might go into a lazy eye or amblyopia, which cannot be recovered. But the patient level, they don't have this information. So all that I would like to say is all the systems have their own role, and this we should accept as such. And they should remain very pristine to their knowledge. What the government has done for the system, like especially for surgical specialities. Now, even the Ayurveda doctors, even Siddha doctors or Unani doctors homeopathic doctors can do surgery, provided they get a 6-month certification course, which is a huge disservice to the kind of things we aspire for. Because I will not go to such a practitioner for my surgery, because it's a hardened learning curve kind of thing we are doing too. So all this mixopathy would never help. All these things you have to stay true to your knowledge, and the dialogue should happen if we are to produce some positive effect in our community. That's all I would like to say.
Ayurvedic doctors, they actually the 6 months course and doing surgery, they themselves should say this is not possible. Say the MBBS doctor who is doing internship or whatever 6 months, if he is finishing the surgery posting, he is not supposed to do a surgery on his own. We have to do MS another 3 years. Then only he is becoming a surgeon. So even if the government is saying that, the Ayurveda people should say, no, we are having our own set of things, and we are proud about our legacy. Our treatment is different. We cannot become a surgeon by after 6 months, because this biomedical people are becoming a surgeon after 3 years of practice. That should come from the other side also. This is not like one system should fight against the other. Everyone should acknowledge the benefit and pitfalls of the other system and should come. It is not that simply we can, in order to bring up the other system, one system should be forced to step down. Like a short gap, within 6 months, nobody can learn anything. Thank you.
I just want to bring another perspective. as you told a story about diphtheria. So, in our public health, what we study is the basic principle for providing primary health care is one is equity, then with community participation, with locally available technologies, with intersectoral coordination. That is what we wish to provide. So, I think it's very important to have integrate all healthcare providers, all systems into the delivery of primary healthcare. But when we talk regarding the medicines we give or the chemicals we give, it's very important that regarding diphtheria, since they are poor people, we are denying them an already proven medicine or proven preventive strategy, because they could have taken vaccine by we don't know why they didn't get it. And diphtheria antitoxin, though it is difficult to get, that is life saving. So as Anita told, I think regarding the human rights perspective of that children, they are denying the choice of getting that antitoxin. So, in primary healthcare, if we are doing like that, I think it's against human rights of them. But after getting evidence, we may try to implement that. But the first and foremost thing is, as Anita told, we have lot of stories. Recently, many viral hepatitis A death has increased in Kerala. One of the main reason they are telling is that Ottamuli, that is a single dose medicine they are taking. And in a recent, we are going to field work in tribal areas. So last year, a 2-month-old baby died there because she had diarrhea, and the JPHN had told her to take ORS, but they went to a traditional practitioner and they took some medicine, and she got liver failure and died. So there are many stories like that also. So denying an already proven medicine or proven healing choice is against the human right of the patients, because they don't know what are the provisions available in here. Trust is very important. Why they are taking that choice is depending on many factors, but that is very important also. I think that
The children were being administered all the other medicines that were already available. No human rights were being denied to them. 1 second. I don't know. And this is a very long time ago, more than 20 years ago. So vaccine won't work when the child has diphtheria, no? That's what I'm saying. So if the child already has diphtheria, at that time they have to have some other intervention, right? There has to be some medicine for diphtheria. Whatever medicine they were being given, that medicine did not work. And children were dying. They did not know what to do, in which case this Vaidya was giving medicine because nothing else seemed to be working. His medicine worked at that point in time. Now we can do a whole study. The point is, even if we do a study, you won't read it. That's the problem, no? Now the thing, I think the real problem here is to recognize that some other things work. I agree that this discussion is not going anywhere, because it's about just simply recognizing that at that point in time, this Vaidya gave a medicine that worked when other medicines that were accessible, being used, did not work. There was clearly no vaccination beforehand. Otherwise, why would the children get diphtheria? No. So nobody was denying anybody human rights by not giving them the medicines. Medicines were available. I just want to point out that. The other thing is, this whole thing about surgery in 6 months. When you look at an intervention like this by the government, I'm a student of politics. If you want to discuss how a public policy is introduced, do understand that there's a lot of politics behind introducing that, any policy. And in that, there is a great deal of contestation within the system also. So there will be many people within the system who would say this is not right. They will be overridden by others who will say, no, we need to introduce this. And we need to understand what politics is going on there. Why is it that this kind of a completely nonsensical policy is introduced? In my opinion, I completely agree with you. How can anyone learn surgery in 6 months? That's nonsense. Now, if we are looking at Ayurvedic practices of surgery, which then will need to be, properly explicated and so on and so forth, documented, and people have to understand what that is about. If that is what they are doing, that's very different. But to say surgery means biomedical, that's very different. So one needs to, to see what's going on, how a policy is introduced. And so not every policy is defensible either. No, it's wrong. I have no hesitation in saying that.
But this idea about public, which is used in medicine, is a strange idea. The idea of public is actually formed in the cultural, literary sphere. You know, that is the sphere where we all debate about what is the public good. There are various conceptions of good are possible. But doctors are using it in a sense, maximum utility of the maximum number of people. Let's find measures and impose on everyone. Right? That's a strange notion of public. Maybe something which we need to really look into is what is this concept of public, which the doctors are. Yeah, that's what that public. We are, yes, but the idea is you want to find out the correct method, like vaccine, and should be imposed on everyone. But that's not the idea of public. Public is a concept before doctors use it, right? Yes, that's.
But this is
No, this is the question, not a debate.
It's not about doctors, first of all.
Yeah,
Yes,
but these
there are-
concepts, doctors didn't invent the concept of public, right? It was invented, tested, debated by various other people. So we are just curious about people in maybe medical humanities should look into it. This literary public sphere and, the medical public. What do doctors mean by public? We need to understand. Otherwise, we seem to think that the same public, right? The public, which, as you said, we the people of India, is not the maximum number of maximum utility measures. Right?
Yes, absolutely.
And the second is that's very strange. There is nothing called public physics. There's public medicine, there's no public physics. But whatever is done in physics, as he was saying, is non-interventionist, but there is market and technology in order to make it available to everyone. Now, what is the situation in medicine? There are non-interventionist cognitive mapping at some points of biomedicine, but the rest of them may not have this. So maybe they are confessing some inability of that discipline when they say public medicine. Not like we need to do good for everyone. Because physics doesn't have a public physics. The third thing is that I am very skeptical about the dialogue between traditions. Right? People have some way of saying that, look, there are many traditions, each have their own way of looking at it. See, if you are a serious cognitive practitioner, you have more serious commitments to your tradition. And I think a homeo practitioner has more commitment to his knowledge claim than saying that, look, these are all various stories which we all call like coexist. It's a religious thing. Each religion has their own beliefs, so we should all coexist. But knowledge practices are not like that. So heavy commitment is involved. So if you look at the way today modern hospitals, other traditions, this is not because modern medicine is tolerant towards others, purely commercial interest, right? Now they need an Ayurvedic and they won't allow a homeo doctor to be around, right? Usually it's an Ayurvedic thing. And then the doctors will decide, okay, rheumatism, few things, Ayurveda is right, or the market will decide. Now, can we think about a politically conscious way of adjudicating between these traditions? We can't leave it to doctors. In COVID happened in Kerala, they arrested some alternative people so that they will not speak in the public sphere. They were arrested. Right after that, what conversation is possible here? And one of them died in the prison. And that somebody had to write a story about his life history, right? Why he died during the COVID time in the prison. No. See, that's not. I'm not contesting the idea or blaming anybody. I'm saying a debate, dialogue. Let us not start with the agenda of dialogue. We need a more radical political option. We can't leave it to doctors to decide. I don't want, as a patient, when I have suffering, I have to worry about which tradition to go for.
Sir, actually, there is another agency involved in that. We know that polio vaccine is not the solution
we can't leave it to
polio.
doctors. We can't leave it to doctors. We can't leave it to patients. We can't give it to the state to decide, okay, we will find out who are the Ayurveda doctors. We will fade their number of years of training. No, I am somebody who always go to a quack. When my car breaks down, I don't go to a service center with engineers. I go to a local service guy, right? The same way I always go to a quack. But then I need a politically conscious mechanism here, so friends of medicos, which will enable me to go to which doctor to go. Right.
My concern there is again the problem of conflating too many things, and medicine becoming health, health becoming public health, and then when you have the state starts deciding, and then decisions of the state being seen as decisions of the doctors, which many a times it is not. So, and then, but the doctors do have 1 week, she and a team of doctors were going from the largest district in Kerala, Malappuram, to find out such people and prevent this. She said that we can't sit in our vaccination clinic or this because of this particular event. All of us are running after this. So sometimes it's, I don't know, when we say this, sometimes I believe it's the state, and I don't think I feel the same thing which the state is telling me to do. So where do we draw these lines?
Whether to treat, whether to die, whether to not treat, it's all my, it is my right. Okay. I know the state decides. Yeah. Yeah. So I'm just thinking in a very, when you told that you have all the right to go to a quack, knowing that a quack, whether you take your car or your body, it's immaterial. Yeah. Okay, you go. That's it. So, yeah, that is what. So, what helps you in deciding that agency is your intellect or social, whatever. So, whatever. But I think that is the question. I mean, then what is, I'm asking in a very naive way, I know. Then what we are talking about establishment, state has the decision power, all these things. And why do you need this public health systems as such? Everybody can be, yeah, I fully agree to that. So you can choose. So it's what is the very philosophical answer to that? Or am I telling the answer as right?
I agree. I think that we are conflating many things. When we are talking about, when I am talking about conversations, I am actually talking about genuine knowledge production that is happening in conversations between researchers and practitioners of different systems who are willing to listen to each other, understand, and draw what they can learn from each other. And in that process, when they have to translate their concepts, they translate their ideas, they attempt that translation, however difficult it is and however limited it is. And I would actually deeply respect this kind of knowledge production, because let's also not forget, today we are very, divided into silos. So there's Ayurveda and there's this, all knowledge systems are very separate and they are in different institutions and so on. So any kind of knowledge exchange is a very big deal. But knowledge exchange has been, if you read the history of knowledge production across the world, there's some fascinating, historians who've written on how knowledge has been produced across the world. You find that people have constantly produced knowledge by listening to others who differ from them and draw from them, and they have enhanced their own knowledge system. The other from whom you have drawn has also enhanced. So this has been the way in which knowledge has been produced and developed by human civilization. So that's one level. Now, in the contemporary, it becomes particularly important because this knowledge production is limited to certain kinds of institutional spaces and legitimation processes. So what are the institutional processes? Institutions are research centers where there has to be a protocol by which all these different knowledge systems can come together. There has to be funding. There have to be people. There has to be, training, and you have to recognize that some people are trained to do something or the other. So all of these things need to be put in place before knowledge can be produced. This is the story of this is how I recounted to you how the clinical trials were done by Ram Manohar. And then, of course, there's a whole legitimation process, which is by peer review. So then that work is then put into a certain format, which is recognized by certain journals. You put it in peer review, etc. So today, this is the format by which legitimate knowledge is produced. So if you want a conversation, which should be the default of knowledge production, then that conversation, unless it is conducted in this context, it does not have legitimacy. Now, why I'm saying this is because I don't know about doctors here, but the doctors I know, and again, I mean, it's anecdotal, but just as a point which I'm sure will reverberate, there are many doctors. Today you are saying, and it's absolutely right, that these hospitals have a commercial interest in having, including Ayurveda. And it's biomedical doctors who decide which conditions can be handled by the Ayurvedic practitioners, and that has its own issues and so on. But on the ground, there are many doctors, biomedical doctors, who recognize that certain conditions are better handled by either a homeopath or Ayurveda. And the reverse is also true. There are many Ayurvedic and homeopathic practitioners who are faced with a patient when we are talking about what is right for the patient. And I think 99% of doctors are actually, I don't want to hazard any numbers, Baba, that's always a problem. There are many doctors who are very responsible and who feel that, no, this is not something I can handle. I should send it on to the other person. I wish sometimes, I have been observing this for such a long time, I wish I had documented, I'd done a systematic study. How many doctors exchange, and they exchange with great respect for the other person and efficacious. They manage to help the patient, which is the most important thing that the doctor cares about. And most of these doctors don't have any documentation of their own. I have asked many of them, please, can you give me, I said, now Madhulika, are we going to spend time documenting or just treating patients because they're crowded? They have so many people to treat. So that is, this whole knowledge production sphere is something else. And then when we are talking about how we take this into the public health realm. Now, problematized as it and deeply contested as it were, this whole understanding of what is the public, how do we, and this conflation between biomedicine, medicine, health, somewhere you have to start from. I mean, the reason I started where I did was because if you start there, then you never come to discussing this point at all. So one has to presume a few things, and I'm also beginning with what people normally presume as well, right? That public health means medical interventions by the state. And I am saying that if the state is responsible for providing healthcare, which many of us feel that it should be, then how best can it utilize already existing knowledge, already existing base that is available with people, instead of going through the painful processes which have been difficult to implement. So yes, I am talking about primary health because I feel that public health should be primarily about primary health care. Public health also can be many other things. So this big, huge legal war that was fought on neem, on turmeric, and on basmati. These were the three things on which those legal battles were fought. And the government of India actually at that point had intervened and fought those battles. And the ICMR had produced evidence which made it possible in a US court to show that you cannot patent any of these things in the United States. So that has happened. But those are issues. I was not concerned with those issues. I'm concerned with primary health care. And I feel that Ayush has a very important role to play in primary health care, which is why I was talking about it. Right? So one needs to delimit, and that is what I was doing. In that, invariably, there's some conflation. That's a problem. And one will need to address it. But as you see, that even starting with the fundamental point that they can be of value is a contested territory. So to take it anywhere beyond that is a later question.
What I understood is that what we are discussing is the hegemony of modern medicine or biomedicine, and how that is based on what we call as evidence, or what biomedicine claims as evidence, and how this evidence is being produced. And when you actually really look into it, for example, I read that a paper that was sent on evidence-based medicine, in that they critically look at what trial is and what the evidence, what actually is evidence. That is what is being questioned. So if to an extent, when you say that evidence is actually assumption or your belief, isn't it similar to the what we call alternate systems of medicine and their beliefs? So aren't they at the same platform?
Today, I don't.
No,
think we're
not today.
discussing-
Till now. So I'm trying to bring clarity to my own thoughts, because this is new to me. No? The subject is new to me, so it's very difficult to understand also. So that is one thing that I understood. Second thing,
This is a very broad brush stroke. There's a lot more nuance.
Exactly.
It's not as simple as therefore evidence is equal to belief is equal to Ayush. It's not that kind of an equation.
No, I understand that there are some nuances to it, definitely. But then, I am also talking in a very superficial way.
Fair enough.
Okay. Then, and because of that, there need to be an understanding that, and because of this hegemony of modern medicine, the other systems are not actually getting a platform to present their evidence, or whichever way they call their evidence, whatever they call their as evidence. It need not be same as what biomedicine call as evidence. They have their own evidentiary or belief system or evidence or whatever we call it. And so there should be a platform for these. So I think that was something that was discussed yesterday. That's what I understood. And today's, when we come to public health, what confused me is I really didn't get where this discussion was going, because Sanil sir said, like, who has to decide? The doctor should not decide, the patient should not decide, then the state should not decide. Then I really didn't understand that concept. Whether, or is it like nobody should decide? Or there should not be no decision?
That's the question for Sanil, I suppose. This is not what I was saying. I didn't say any of this.
See, that was a very confusing statement for because a decision has to be made somewhere. So
Sort it now. You created all the confusion. I was saying something so simple. You complicate it. Now sort it.
sir, in that context, I would like to ask this also, because when we learn, what we learn is this primary healthcare actually came after the realization of healthcare as a right, health as a right, which was introduced by Meher, and it was kind of political, wasn't it? That decision by him was actually political. Health as a right is a political decision. It is not a biomedical decision. That health is a right. That whether you are a Dalit or whether you are a tribal or whether you are a Muslim or whether you are a woman or a transgender, you have a right to health. You have a right to access quality health care. That is a political one. I don't think it is a biomedicine concept. It's a political one. Yeah, yes. So medicine is political. Always, see, something that we learn.
By larger systems, and we are, I don't know, it's probably a scary thought, but we are probably just, Malayalathilulla word karukkalana. I don't know what the English word, pawns probably in a larger system.
That's what she also said, no? Cogs in the wheel.
Yeah, why I am saying that is because I worked a bit in TB, and Dr. Sanjeev Nair, professor at Thrissur, who's worn many caps, from a district TB officer, WHO consultant of TB, researcher of TB, so many things. He shared an experience of a respiratory medicine senior professor who, when we first went with the thrice a week, intermittent, we call it intermittent regimen, this person was like going up in smoke. How dare you say such nonsense? Intermittent regimen? We will only give you are doing everything is wrong. This was in the 2000s, late 1990s, early 2000s. And this person was opposing it for 3-4 years. Finally, one day, the person crossed over to the intermittent side and then has been giving intermittent ever since.
So who was this person?
Then in 2019, 1819 WHO shifted. So then this person was saying, what WHO is saying daily, it should be intermittent. So that's what I'm trying to say. I don't think each of us is scientifically looking at, we are trying to get by. When there is a person sitting in front of us saying that I have this, with whatever we have been trained, with whatever armament of words, tools we have, and experience, we're just trying to get through. So I don't think it's like medicine is deciding everything. There are very strong, powerful bodies like the IMA, and the power is disproportionate. Ironically, if a woman is raped in a hospital, we don't get the same kind of reaction. When the hospital is supposed to be serving the woman and she gets raped there, the reaction, I'm very shocked by what happened in Kolkata. But there's also this debate among doctors that, you know, doctors' bodies are different from the non-doctor woman's body. So I agree that there is this big power disparity, but I don't think that medicine is very free of the clutches of things beyond medicine.
Actually, sir, when we tell my body is my choice, that choice is also a result of political process. So my body, I don't have, when somebody take that choice, that's not their choice actually. There is a big process. Yeah, I understood.